Kausar. And now I would like to introduce Mr. MD Jobairul Islam. MD.
This is my contents. Breast cancer is a global public health concern, and breast cancer is a major global public issue and top causes of cancer deaths in women. Almost half of all breast cancers are diagnosed in Asia, and shockingly, Bangladesh has one of the highest incidence in the Asia region. Over 13,000 women are diagnosed annually, with over 7,000 deaths, according to the IARC data. Breast cancer burden and the role of the radiotherapy. Radiotherapy is an integral part of the treatment of breast cancer. Radiotherapy reduces the local recurrences by 50 to 70% post-surgery, and tumor weight boost further lowers recurrence risks 5 to 10%. And it's already proven to reduce local recurrence and risk of death from breast cancer. Breast cancer boosts radiotherapy why it matters. Because the development of refined surgical technique has made breast conserving surgery the most common approaches, preserving breast anatomy while minimizing deformity. With 70 to 90% of local recurrence occurring at the original tumor site, a focused high-dose boost to the tumor weight irradiates microscopic residual disease. And one meta-analysis already showed that the boost radiotherapy reduced the 10 to 10 years local recurrence risk from 10 to 6%, whereas the 40% relative risk. In my boost strategy overview, the first of the I will discuss about sequential boost radiotherapy, where the traditional sequential tumor boost in 40 to 50 gray in whole breast, after that 10 to 16 gray per boost, and while the in additional 5 to 8 session for the boost radiotherapy. So what is the pros? Is simpler planning, widely accessible, and the cons is the prolonged treatment, potential for dose overlaps in OARs. In boost strategy, SIV techniques. In SIV techniques, we used 48 to 52 gray tumor weight, while the 40 gray in the whole breast in 15 fractions. It delivers a higher dose to the tumor weights simultaneously with the whole breast irradiation in a single plan, whereas the pros is a shorter treatment duration, reduce patients' burden, optimizing the OAR sparings. And cons is that requires advanced planning like IMRT or BMAT to avoid hotspot. So what is my study objective? Compared to SIV and sequential technique, main goal is the dosimetric qualities, radiobiological effects, and the cost effectiveness. And in my inclusion and exclusion criteria, include early stage breast cancer, post lumpectomy with clear margins, available to both SIV and sequential plans, and in exclude prior radiotherapy, bilateral cancer, metastatic disease, etc. And my cohort design is that for all our 15 patients are left breast side, and treatment techniques are either IMRT or BMAT using Eclipse and algorithm Tripole. And in dose administration is the SIV in 48 gray in tumor bed, while the 40 gray in whole breast in 15 fractions, and while in sequential 40 gray whole breast plus 10 gray in additional 5 fraction boost. And plan was evaluated according to the RTSG 1005, where the more than 95% of breast PTB will receive more than 95%, and underdose not any part of the PTB shall not exceed 93% of prescription dose, and overdose not accepted in my institution 110%. In OAR below the 4 gray, epsilateral B20 less than 20, it's an LAD and contralateral breast also evaluated. So in the comprehensive analysis framework, the treatment plans as the cost effectiveness, as the find out the cost, outcomes at time, and also dosimetric analysis, radiobiological analysis, and statistical analysis. In my radiobiological assessment, first using the biological effective dose. I had used alpha beta ratio in the tumor for tumor 4 because an UK start trial using the alpha and trial A and B about 4 gray irradiated moderate sensitive for fractionations, whose clinical trials in UK start trial A and B already mentioned. And ECB evaluated according to the Poisson models, and NTCB also LKB model, where is the In LKB model, TT50 used for lung is 30.8 and M is 0.37 and N also 0.99 and heart in TT50 48. So what is the dosimetric analysis? In first of is the SIV and is sequential is the mostly similar. There is no significant difference in the B95 and CI also mostly same. And what is the main advantage in SIV is the maximum dose is reduced in the SIV and monitor unit also almost 50% less. In ipsilateral lung, whereas the B20 also reduced significantly, 15% in SIV, whereas the in sequential in 70%. And heart also not significantly sensed, but it reduced in SIV techniques. It's also contralateral lung and contralateral breast in same not. P below is not significantly sensed, but several times, mostly patients are reduced in SIV techniques. So that's the important part of the radiobiological analysis. There's the tumor. Tumor BED is 86, whereas the sequential 81, and TCP is increased, not significantly, but a small gain. In NTCP also same. So what is the key findings in my 15 patients? Equivalent excellent target coverage in the both plants and lower high dose is placed with SIV and lung dose also reduced. And critical interruptions, reduction in hotspot is the likely clinically meaningful, may reduce late skin fibrosis and improve cosmetic outcomes. A small absolute TCV gains can still improve on the population scale and microscopic disease, where dose reductions are modest but directionally favorable. In radiobiological already discussed in the tumor control probability increased, sensitivity also decreased, and also cost effectiveness, it's workload management, reduced treatment time, and patient benefits is cost savings. It reduce the additional 5 or 4 fractions. So in my conclude, SIV prescribes target coverage while the improving dose homogeneity and markedly reducingly high dose is placed. SIV modest spares lung and heart and increases tumor weight. A small model TCV gains without a clear NTCV penalty. And operationally superior is because it's the fewer fraction, lower MAUU, and shorter machine time and measurable cost savings. An improved therapeutic ratio, TCP high, reduced NTCP, and the better patients center or flow. So the takeaway message: SIV offers better dosimetric, plausible, and biological advantage, and its clear operational gains, promising as the boost strategy of choice when they adopt with careful QA and outcome monitoring. Thank you.
Uh, Thank you, Mr. Islam, for your nice presentation. I hope radiation oncologists would